Thank you for joining us today for our webinar, EoE in Adults, From Diagnosis to Treatment. I am Jennifer Gertz, Executive Director of Food Allergy Canada, and today our expert joining us is Dr. Millie Gupta. Before we get started, I want to note a few items. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions upon registration. There are some common questions that we will tackle in today's session. If you have additional questions during the session, please submit them in the chat box throughout the webinar, and we'll try to get to as many of them as we possibly can. This webinar will be recorded and shared on foodallergycanada.ca afterwards. First, a little background on the session today. Under the umbrella of food allergy are several different conditions that present with adverse immunologic reactions to foods. They can be IgE-mediated, non-IgE-mediated, or a combination of both. The most known class of food allergy is IgE-mediated food allergy, in which symptoms result from the body's immune system making IgE antibodies. These antibodies cause the immune system to trigger an allergic reaction when a specific food is consumed, and the reactions are reproducible, typically occur quickly, and can be anaphylactic, which is potentially life-threatening. Non-IgE-mediated food allergy is a lesser recognized class of food allergy in which other components of the immune system react, and it doesn't involve IgE antibodies. This class of food allergy usually causes gastrointestinal related symptoms, and these symptoms do not appear immediately after consuming a specific food, nor lead to anaphylaxis. However, the impact of this class of food allergy can be significant, leading to substantial declines in health and quality of life. Today's session is all about a specific type of non-IgE mediated food allergy, eosinophilic esophagitis, or referred to as EoE. We will focus more on adults to complement our previous webinar on EoE that focused on pediatrics. Also, before the end of the year, we will have a session dedicated to FPIES, another type of non-IgE mediated food allergy, as we work to raise awareness of these conditions and help support those who are impacted. Some of you may have joined us today because you or your child or your patient has a formal diagnosis of EoE. Others may have tuned in because they've experienced one of the most common symptoms of EoE, difficulty swallowing or feeling like food gets stuck. And so you're here because you are just interested in learning more about this condition. To help get a sense of who's in our audience today, we'd like you to participate in a quick poll. If you could please select the one that describes your situation the best. Diagnosed with EoE, either you or your child, suspect EoE and want to pursue a diagnosis, have patients with EoE or suspected EoE, and none of the above. If you can please take a moment to fill out the poll, that would be great. All right. Now let's see what we've got. So 20% of our audience is diagnosed with EoE, 31 suspect EoE and want to pursue a diagnosis. We've got 30% who have patients and 20% in none of the above. Great, well, that's really helpful. It gives us a sense for who's joined us today. And this is also helpful to our expert for today's section, who I'd now like to introduce, Dr. Millie Gupta. She is a clinical associate professor in gastroenterology and hepatology at the University of Calgary. She is the lead for the Eosinophilic Esophagitis Clinic and co-lead for the Southern Alberta Barrett's Endoscopy Program and the Calgary Gut Motility Center. Thank you for taking time out of your busy schedule today to be with us. So over to you, Dr. Gupta.
Hi, everyone. Thank you so much for the invitation. I appreciate all the work that Food Allergy Canada has done and continues to do on patient education. Today, as already I mentioned, I will be reviewing the topic of eosinophilic esophagitis. During this talk, I will reference eosinophilic esophagitis as EoE. The objectives for today's talk are to go over the patient journey with the pre-diagnosis, the diagnosis, and post-diagnosis stages of EoE, what we mean by the term EoE, what the symptoms are in adolescents and adults, how we diagnose it, the current treatment options, and the recommendations on long-term management. The story of EoE is that it is a challenging disease to live with and a drawn-out process from the patient's point of view. Patients will describe food impaction as the most common symptom they experience, but it can be up to a decade before they finally get the diagnosis. During that time, emotionally, many experience fear, worry, loneliness, anxiety, frustration, and confusion. Emotional distress, limiting normal feeding, and restricting social activities were described by patients as ways to manage the difficulty of swallowing that they did not know was a medical condition. More than 85% of patients have described modifying how they eat to avoid symptoms from happening in this pre-seeking care stage. During the diagnosis stage, the intensity of the negative feelings may peak, but then there is also a positive change in symptoms as patients come to realize their symptoms have an answer. Emotions can continue to be up and down during the treatment phase, the remission or monitoring phase. The fear that symptoms can come back remain even after treatment resolves inflammation and symptoms. This slide shows you the different ways in which infants, children, and adults may experience EoE. This slide is from the American College of Gastroenterology patient education website. As you can see, reflux that does not respond to medications can occur in this swallowing condition. It is not normal to have regular challenges swallowing food. It can be painful to swallow, or it can be linked with chest pain. Children may appear to be picky eaters or lose weight. They may get nauseous or vomit. Younger children can be poor sleepers, and overall, EoE is linked with reduced quality of life, just like other chronic medical conditions. Eosinophilic esophagitis is a swallowing problem that occurs because of uncontrolled inflammation in the esophagus. The challenges with swallowing can be slow in its start, and patients may not realize they are struggling until they have made a lot of changes to their lifestyle. Trouble swallowing will result in folks modifying how they eat and drink. There are various ways in which patients may adjust to the difficulties of swallowing. For example, they may choose to chew their food excessively until it's a paste and easy to swallow. They may choose to stay and be the last one at the table eating. They may use liquids after each bite to lubricate and ease movement of the food. They may avoid certain textures or consistencies of food, like steak or chicken. Other ways patients may adjust is to avoid going out in public to eat, because it induces anxiety and fear around the possibility of choking. Now I will break down the meaning of the term eosinophilic esophagitis. First, an eosinophil is a white cell in our body that is triggered by allergic conditions. The eosinophil on its own is not abnormal to have in the body. It is an essential component of our immune system, but it does not normally live in the esophagus. The diagnosis of EoE is the finding of eosinophils in the wall of the esophagus in high concentrations. This picture reflects how diet, environmental triggers, and genetics are involved in a complicated manner, triggering and promoting the disease. This image is from a research paper. We think the collection of eosinophils in EoE occurs due to a trigger from a food or possibly an airborne allergen like pollen. Researchers have shown that the eosinophil is not the only white cell present in the esophagus. As you can see in this picture, there is a wide range of immune markers and white cells that are involved in the inflammation. This specific type of inflammation that we see triggered in EoE is type 2 inflammation. It is the same type of inflammation we see in allergic conditions like asthma, eczema, allergic rhinitis, to name a few. I know the audience today is diverse in its interest in this area, so I aim to provide superficial information on the development of EoE. It will help explain the treatments we offer patients. To diagnose this condition, doctors take samples of tissue using a camera called a gastroscope. On your left, the black tube in the esophagus is the gastroscope. As you can see, it is inside the patient's mouth and their food pipe. which is the esophagus. The appearance of the esophagus is something the doctor will take notice of and record in their reports. For the image on the right, you see the various ways in which the esophagus is changed with chronic inflammation. You can see rings, strictures, white specks called exudate, linear furrows, or what we call train tracts, and narrowing of the lumen, or the diameter of the esophagus. In the picture on the right, they have an image of an eosinophil causing injury in the esophagus. And on the picture in the left, you can see the rings I'm talking about clearly. It gives the esophagus an appearance of a narrow tunnel. Chronic inflammation and scarring causes this narrowing, and it can also cause stiffness in the esophagus. The narrowing and stiffness causes food to get caught in the throat or esophagus. Again, in the picture on the right, you can see the reduced diameter of the esophagus closer to the stomach. It's been highlighted for you. Getting food stuck in the esophagus can be a medical emergency, requiring an emergency removal of the food by a gastroscope. Sometimes, though, the food passes on its own in a few hours or minutes. Having this occur is a medical concern, and it warrants investigation. In more than 75% of cases with choking, there is an identifiable reason for the food getting stuck, which is why it's important to see a doctor if you have had an episode of choking. If you hear the term fibrosis, it is a medical term referring to the scarring in the esophagus that causes the narrowing. Here is a close-up of the lining of the esophagus. On the left is what a normal esophagus lining looks like. The three images on the right show inflammation of the esophagus in EoE. It can create white, sticky spots called exudate. The inflammation can go undetected for many years, and that is why we get scarring. The type of scarring can either be called furrows, which is highlighted by arrows in the second picture, and what I was calling train tracks. And the last way it can present is the rings on the very right of the image, and that's the last picture. The adjustment to food and eating can be a factor in delay in timing for diagnosis of this condition. This disorder can occur at all ages, but often there is a 4 to 10 year delay from start of symptoms to diagnosis. Despite our better understanding of this condition in the past 30 years, we still find this gap to be present, and it's unclear to us what other factors may be contributing. This matters because we know the longer the time between start of symptoms and diagnosis, the higher the chances the patient will have trouble swallowing and develop chronic scarring. Here is another slide to show you this. The horizontal line is called the x-axis and represents here the number of years a patient has had untreated EoE. The vertical line, called the y-axis, shows how many patients with EoE do not have strictures. As you move forward in time, following the horizontal line, the chances of patients not having stricture drops. Not everyone with this condition will develop scarring, but most people who do not seek out a checkup for swallowing troubles are at high risk. This slide shows you the steps researchers believe occur in the patient with EoE. First, they have a normal appearing esophagus as shown on the leftmost picture. Then an allergen triggers it to develop inflammation, and then the second image occurs, with exudate shown as white specks, rings, and straight lines as furrows. As this inflammation keeps going on, the esophagus will accumulate inflammation and develop fibrosis. The scarring that we've already mentioned. The scarring will keep going on because the inflammation has not been stopped. As this happens, the esophagus gets narrower and stiffer, making it hard to swallow. Below these pictures of the esophagus are sections called histology, and this is what the lining of the esophagus looks under the microscope. In the bottom, there are two bars with colors. The pink and yellow color bar reflects the amount of inflammation and scarring. Children are more likely to have the inflammation variety of EoE, which is highlighted as pink here. Adults are more likely to have the chronic scarring and stiffness variety, which is highlighted as yellow. But this is not always the case. Some children have disease with scarring, and some adults do not have high levels of inflammation to cause scarring. Treatment, which is listed below in blue and orange bars, will be chosen based on the nature of inflammation we see in the esophagus. Children are more likely to need medicines or diet for management, which is highlighted as blue. Adults are more likely to receive medical diet treatment plus dilation, which is highlighted with the orange. The frequency with which we are diagnosing this condition, called incidence, is rising. The top graph shows you the rates at which EoE is being diagnosed in many Western and European countries. Unfortunately, we do not have much data published from Africa and Asia, so we don't know how common the disease is there. We aren't sure why this condition is being picked up so much now than before. Maybe it is a combination of doctors looking for this condition, or maybe there's something changing in our food and general environment that's driving its high diagnosis numbers. For now, it remains unclear. We do know this condition does not reduce lifespan. So prevalence of this condition, which means how many folks with this condition are in our communities, is continuing to go up. This is represented in the bottom graph. Research has shown that more than 75% of patients with EoE will have at least one allergic condition or food allergy. Type 2 inflammation is the key driver. There is concern that allergic conditions can trigger EoE and vice versa. So, it is important to consider seeing an allergist, lung doctor, or nose-throat doctor if you may have bad eczema, asthma, or sinusitis. Your family doctor can help guide you on whether you need more specialist care. An allergist may also be helpful if seasonal allergies are hard to manage on your own. All ages and genders are impacted by this condition, but ages 5 to 14 and 20 to 45-year-old are affected the most. Men are 3 to 4 times more likely than women to have this condition. There is a tendency for a positive family history, either for eosinophilic esophagitis or general allergic conditions. As many with EoE will know, there is a seasonal component to the disease, with winter months being less intense for symptoms than summer. If you live in a dry and cold climate, then you are more likely to have the condition, which raises the possibility of an environmental cause. However, just because you don't have allergies does not mean you cannot develop this condition. We still have a lot to learn about this disorder. Before I move on to talk about treatments, it's important to recognize that eosinophilic esophagitis is generally not life-threatening and has not been linked to cancer. However, it is linked with eating disorders, poor quality of life, anxiety, and depression. So it's important to seek help for general well-being, in addition to the challenges with swallowing. That may be in the form of support groups or psychologists. We have learned from chronic medical conditions that it is not possible to help the person without considering their overall well-being, but we still have to do better for our EoE patients. Treatments for EoE are limited to keeping the disease in check, as a cure does not exist currently. We know regular treatment reduces the development of scar tissue, rings, furrows, and fibrosis. It can help patients have a meaningful quality of life. So the benchmarks used to monitor success of treatment are threefold. We need to see that there is improvement in patient symptoms and there is healing of the esophagus. The healing of the esophagus is represented in two ways: the histologic activity, which is the amount of inflammation in the tissue samples taken during the scope, and the physical appearance of the esophagus, which is documented during the scope as endoscopic activity. The three treatment options are captured best by the acronym 3Ds: drugs, diet, and dilation. I will review each one. Drugs focus on suppressing inflammation in the esophagus. Diet focuses on eliminating the trigger food that is implicated, and dilation on managing the scar tissue that has developed over time. A key takeaway from the treatment slides I will review is this: symptoms alone are not enough to guide management. Unfortunately, we know from research Symptoms do not match the level of inflammation in the esophagus. Therefore, managing EoE requires conversations with your doctor. At the end of the day, the decision on how to manage EoE must make sense to you. There are 3 drugs we use for EoE. Proton pump inhibitors, or PPIs, are reflux medications that we commonly use for ulcer and heartburn management. It also has a role in EoE, but how it works is not entirely clear. What we know is that when you take the medication twice a day, up to 60% of people will feel better, and 50% will have healing of the esophagus. Many patients who are responsive to this medication may need to take the medication for at least 12 weeks before doing the camera test or the scope. It seems some patients are either slow to respond to the drug, or they may need time to get consistent with taking it 2 times a day. Either way, if this medication is working, it's reasonable to stay on this, either as twice a day or to drop the dose down to once a day. Unfortunately, the catch with dropping it to once a day is that you must do another scope to confirm that the new dose is working at keeping inflammation in check. The second medication we consider is topical steroids. It is available as puffers, dissolvable tablets, or compounded slurry mixtures. Topical steroids are not the same as prednisone or systemic steroids. Prednisone or systemic steroids are usually not recommended in EoE. Topical steroids work on symptoms and healing of the esophagus up to 70% of the time. Oral hygiene or cleaning of the mouth is important to follow when using topical steroids to reduce the risk of yeast infections in the mouth. The medication is well tolerated, but on surveys, patients with EoE who have taken this do not perceive this treatment as a long-term option. But like in asthma, we believe it is okay to use this medication long-term, given low absorption in the body. Biologics are immune-modifying medications that are used in various medical conditions. They are chemical compounds. They work by suppressing the intensity of the activated immune system. By suppressing inflammation, the body has a chance to heal, and the patient can have normal function of the specific organ. This type of treatment is common in arthritis, eczema, asthma, inflammatory bowel disease, and now EoE. In EoE, the biologic approved is called dupilumab. Research shows it helps patients feel better and helps with healing of the esophagus in up to 60% of patients who have previously been exposed to some of the other treatments that I've described. The medication is self-administered and injectable. It is taken once a week. It has a low side effect profile, with most reactions being injection site related. It targets type 2 inflammation, like a lot of other allergic conditions. And in fact, dupilumab is approved for use in asthma and eczema too. From a practical point of view, dupilumab does not require blood work or vaccinations prior to starting. Monitoring with blood work while on treatment is also not required. There is a patient support program that liaises with patient drug insurance companies to see how much coverage will be provided. It can take a few weeks to get a final response. Most private drug companies are either subsidizing it or covering it entirely. There is no need to fail other treatments to be considered for this medication. Diet is another treatment option in EoE. There are various diet options, and lately some are not used. The one listed here we don't use anymore is allergy-directed diet. The reason is because current allergy testing is not adequate in detecting the food triggers implicated in EoE. From the top, elemental diet has the most benefit, but it is the most challenging to be on. The black bar represents adults, and the white bar represents children. Elemental diet is a liquid diet with no other foods allowed. The liquid diet consists of pre-digested nutrients, and it's not pleasing to drink. The acronyms 6-FED, 4-FED, 2-FED refer to various number of elimination diets that have been studied. 6-FED means 6 food elimination diet. 4-FED means 4 food elimination diet. And as you guessed, 2-FED means 2 food elimination diet. These diets are successful in EoE, but they are challenging to do. Dairy alone has been studied in children with good results, and a study recently looked at this in adults with promise. So we may see a shift, and physicians may just now suggest you try one food elimination to see if that is your trigger. Here I've listed the 6 food groups we consider. The food groups eliminated are seafood, wheat, nuts, soya or legumes, eggs, and cow's milk protein. The most common triggers in EoE are milk and wheat. Up to 75% of adults will have 1 to 2 food triggers. Up to 40% of children will have just 1 food trigger. As you can imagine, diet restrictions are hard to do. For one, patients cannot rely on how they feel to guide if they're doing it correctly. Also, just because they feel better does not mean their esophagus is healed. Diet restrictions can induce suboptimal nutritional intake and reduced quality of life. Most patients fail to achieve healing due to challenges in completing the diet. In our EoE clinic in Calgary, we work alongside a dietitian who helps our patients navigate this. It is also important to remember that a scope is needed 8 to 12 weeks after starting elimination diet to look for the trigger food. I should mention that it only makes sense to do the diet option if the patient and/or family are willing to do it. The disease is isolating enough already, as I've explained, and this change can further add to socialization barriers. Dilation refers to stretching of the esophagus to break up scar tissue. It is not altering the inflammation process. Its purpose is to provide patients with a bigger diameter of the esophagus so they can tolerate food and medicines well. We know from research that diameters less than 17 millimeters have a high risk of food impactions. A normal esophagus is about 17 to 20 millimeters in size. Treatments with diet, medicines, have been found to reduce the need for future dilations. Adults and children can have dilations if required. Combination treatment refers to mixing medicines and diet to heal the esophagus. There are some studies that show it is helpful to use this. I use this in my clinic quite frequently. There are debates on whether we should or should not recommend long-term treatments in EoE. The ultimate decision-making is in the hands of the patient. Latest guidelines, published in 2022, strongly encourage ongoing treatment in all patients. But it's worth exploring why some patients may not want to stay on treatment long-term. These type of questions are routinely addressed in clinic. They include the concern that the targets for treatment are not well defined and still undergoing refinement and research. There may be side effects to long-term medicines or diet eliminations. Unfortunately, we don't know for sure if there are long-term side effects to these treatments, but what we do know is that treatment reduces the risks of strictures and food impactions. It does change the natural history of the disease. Not everyone is going to develop the scarred down esophagus, so maybe those are the patients who don't have to take it regularly. But as physicians, I don't know how to identify those patient populations in particular. We also do not want to downplay the impact of social anxiety and fear around mealtimes. If medications give patients the ability to go out with their friends and eat, then maybe it's okay to keep going. It is unlikely people will outgrow EoE, but it's possible they may have been misclassified when they in fact had heartburn-related strictures or inflammation in the esophagus. This is a common issue because heartburn or gastroesophageal reflux disease, listed as GERD here, and EoE can mimic each other on scopes and symptoms. We still do not have very good testing to differentiate between the two. Lastly, long-term costs are an issue, and again, it ties in with the monetary as well as psychosocial impact of remaining on treatment long-term. Regardless of treatment or no treatment, clinical follow-up is recommended to ensure that if disease progression does occur, that interventions can be implemented in time. Having said that, there are some patients, physicians, and experts feel strongly about keeping on treatment as the risk of recurrence of inflammation or the return of inflammation is very high. The latest guidelines from 2022 state those with food impactions should not stop treatment. The other considerations are listed in this table and include patients that have a small diameter of the esophagus at the time of diagnosis, symptoms or strictures that come back when treatment is stopped, a history of perforations or tears in the lining of the esophagus, or patients who require repeated dilations. This concludes my talk. I thank you for your attention, and now I look forward to answering your questions.
All right, thank you, Dr. Gupta. I'd invite you to turn on your webcam. Great. Well, listen, there was a lot of information in there, so I think very informative, and we'll dig into some questions. Some of the information you've covered off, but I think it would be helpful to review some of those things just because there was an awful lot of great information in your presentation. The first category of questions is around symptoms, and with the data that you showed us on adaptive behavior and people not sort of recognizing those symptoms, remind us what we should be looking for. What are the common symptoms that someone should take notice of, either in themselves or their child, that would say, gee, I think I probably should pursue this with my doctor?
Sure. So it's going to depend on the age group. So children and infants are more likely to have vague symptoms. So they may describe abdominal pain, they may be picky eaters, they may vomit, not have a good appetite. They may more often describe abdominal pain that is higher up, so closer to the rib cage. And so if you have those kind of symptoms, changing diet, changing food isn't helping, or they start to lose weight, they're getting very malnourished, for example, they're dropping on their growth curves, then definitely they need to be seen by the family doctor and investigated for other sources. When it comes to adolescents and adults, often the issue that we see commonly reported is repeat choking or repeat troubles with swallowing. And as I tried to describe, the swallowing isn't that you have to have an actual food get caught. It can be the sensation that food is slowing down, it is sticking, slowing, or catching, and it takes a while for it to fully go down, or you need liquids to try to dislodge it. If you're having to accommodate how you're eating around family, friends, or you find yourself needing to chew because you've been told you're a fast eater and that's the reason you're having troubles, I just ask you to think twice and say maybe there is something to be looked into. This condition is on a lot of physicians' minds because we're recognizing how common it's become. And so It is okay.
Well, yeah, it was interesting to see your prevalence curves, and I noticed the Calgary line, which is the area that has gone way up in terms of the number of diagnoses. So, when do you typically see patients? Like, at what stage are they at? That would kind of, where are they at in the disease progression? What are you typically seeing in your practice?
Yeah, and it's all over, but mostly it's patients who've had at least a decade of symptoms. And, the research shows this is not out of keeping with how majority of people are presenting to their physicians all over the world. And as I mentioned, we're not sure why we're having this gap, because as physicians, we're acutely aware that this problem is rising so exponentially, but we still struggle to find people early enough, and we really want to try to find tests or biomarkers or other ways of investigating that aren't a camera test, because we're the first to acknowledge that it's invasive, it's time consuming. Right. You have to take time away from work. Can we not find a simpler way to find and check you, maybe at your family doctors?
Yeah, and get to that disease with those biomarkers, get to it earlier in its development. Okay, so how does someone differentiate? Because you mentioned the confusion between EoE symptoms and GERD, and maybe you can explain for our audience too what GERD is, and then help us understand how you differentiate between the two.
So gastroesophageal reflux disease, or GERD is the acronym, is essentially referring to the sensation of heartburn that can present differently in people. So some people will describe the burning sensation in the middle of their chest. They may describe bitter taste in their mouth. They may describe, again, having abdominal pain in the top end of their stomach close to the rib cage. And the sensation of reflux can be very similar to unusual ways of presenting with eosinophilic esophagitis. So symptom-wise, it can be challenging to differentiate between the two. Most often we see reflux in middle to older folks, so 40 years old and above, whereas the difficulties with challenging reflux or difficulty swallowing tends to be all over the ages, but mostly younger. When it comes to testing, there are fancy ways of testing for reflux, and as I've described, there are ways to test for EoE. But unfortunately, the tests for reflux can still be missing EoE, and they can still miss reflux itself. So there's something called a pH test, where we're literally checking the pH of the esophagus, because we know the stomach makes acid. And if there's too much acid in the esophagus, that's what we call reflux. pH testing can pick up a lot of people with acid in their esophagus, but just because you don't have acid in your esophagus on this test may not mean you don't have reflux. You could have what we call silent reflux. Similarly, you can have eosinophilic esophagitis and reflux together. You can just have eosinophilic esophagitis, which imitates reflux. And so if this sounds confusing to you, because it is, it really is. We, as physicians, struggle to differentiate between the two. We will do all the fancy testing, and yet we may still come back to you and say, we're not 100% sure.
Okay, so let's move to diagnosis, and let's first start with the pathway to diagnosis. So, you may have tuned into this, or you may have read some things and you suspect EoE. What happens next?
So usually if a patient is being seen for these symptoms, the family doctor will refer to a gastroenterologist or a general surgeon who does camera tests. When you come to see us, we will review the duration or the length of time you've struggled with symptoms. If you're having food impactions, which means food getting caught, we will often try to arrange an immediate visit for you in the gastroscopy suite, so you don't have to come in twice. When you come in to explain your symptoms, we're also aiming to do the test at the same time. That may not always happen depending on resource availability in your communities. But currently, the camera test is the way we have to identify, diagnose, and confirm the cause of the swallowing trouble. There are research looking at non-invasive ways to assess and check for tissue samples in the esophagus and hopefully be non-invasive, but they are still in research trials. They have not yet become commercially available for this condition.
Okay, now for some of the audience that are in that suspecting EoE and thinking about pursuing a diagnosis, unlike those who have a diagnosis who would have gone through a camera or an endoscopy, can you talk about what's involved in that endoscopy? Like what actually really happens, and are there any risks that are associated with that procedure?
Sure. So with the gastroscopy, so the camera is usually about the diameter of my finger, and it's about 1 meter long. So when we are investigating patients for EoE, this is the gold standard right now. So we would recommend you consider having this test. The test is done with sedation. So it means that intravenous medication is given in small amounts to help you be comfortable. You are considered legally impaired after the test, so it is recommended that you have somebody pick you up and drive you home after, and that you don't do any important legal work or go back to work itself. So you do have to take the day off. When the camera test is being done, there are some risks with the test. The risk is that when we're going in through the throat into the back of into the esophagus, we are going beside the breathing tube. We are not going into the breathing tube. But for some people, it can feel like we are there. So we ask you to just do some normal deep breathing with us. And there are usually 1 to 2 nurses in the endoscopy unit to help monitor your breathing and your heart rate. We're also monitoring the blood pressure. And the reason for that is because when we're giving you the intravenous sedation, we want to make sure we can give you as much as we can to keep you comfortable, but also not incur the risks of the medications itself, which are to suppress the breathing rate. So we don't want that. There is a risk of aspiration, which means accidentally swallowing your saliva into your lungs. That risk is about 1 in 2,000 to 1 in 5,000. So it's not common. And often we'll just ask you to allow us to suction the saliva. We have this dental equipment that we use, similar to dentist, to try to get that saliva. During the procedure itself, really it only takes 10 minutes to do, but the process of getting you comfortable, going in and recovering you, it will take about an hour to an hour and a half of your time.
Okay. Okay. So sorry. So then the endoscopy is done. So what are you looking for? What is it that you're looking for that says, yeah, this is EoE?
So during the endoscopy, the camera is going to go into the esophagus. We're going to look for the rings, the furrows, which I call train tracts, the white sticky spots, inflammation, any suggestion that there is an abnormality in the esophagus. I will record that in the report, but I'm also going to take 4 to 6 samples from the esophagus to send to a pathologist to look under a microscope and confirm if there are eosinophils.
Okay. Now with the eosinophils, one of the questions that came is can those eosinophils be found in other areas of the GI tract and cause other GI issues?
Absolutely. So there is something called eosinophilic gastrointestinal diseases, and that is when the eosinophil is present in the stomach, the small bowel, the colon. It can even be present in the pancreas. So yes, there are other medical conditions that are not EoE, but that behave differently. And they are called, they're encapsulated by the acronym EGID, E-G-I-D.
Okay, terrific. Okay, thank you. Let's move on to treatment using diet. Okay, so you mentioned some common food triggers, and then you mentioned some statistics around, in adults, so many percentage of them, it's usually these two things that are the trigger, and with children, it's this. Can you just revisit the common food triggers and give us a refresh of that information you shared?
Sure. So up to 75% of adults will have 1 to 2 food triggers, but it's possible they may have more. And the most common triggers are cow's milk and wheat. For children, it is also similar, but milk is the more common trigger. And up to 40% of children will just have the one trigger, and it tends to be cow's milk.
Okay.
Mm-hmm.
Okay. And how do you know if diet elimination is working? Like, can you do the elimination diet without doing scopes in between each step, or is a scope required? What's the recommendation there?
So the recommendation is to do the scope, and it's because we need a way to evaluate the esophagus itself, and we don't have any other way of doing that at this time.
Okay, so is there a systematic approach then to identifying those trigger foods?
Yes, so what we usually do is if the patient has chosen, for example, that they want to do the 2 food elimination, we will have the patient meet with a dietitian or review. If they feel comfortable on their own, that's great, but we often suggest a dietitian. They'll eliminate 2 foods. After 8 to 12 weeks, we would book a camera test with the purposes of checking if elimination of those food groups was effective in healing the esophagus. And we will take samples again at that time to ask the pathologist to comment on the number of eosinophils. Based on the response with those 2 food eliminations, again, let's take a case A where the patient does have inflammation healing. If that healing occurs, then we would say to the patient, you should bring back 1 food group. So reintroduce one of the food groups you eliminated, because we now need to sort out which of the 2 food groups was your trigger, because it looks like taking away the 2 food groups was effective.
Right.
And then they have to have another scope in 8 to 12 weeks. Now,
okay, and so, sorry, go ahead.
So case B, where there's no response to the 2 food eliminations, saying those are not their triggers, then we have to move forward. If the patient agrees, we have to move forward to a 4 food elimination or a 3 food elimination. So we cannot, just because there was no healing on the foods they've eliminated, currently the research and the literature does not say you can reintroduce those foods back. They say you have to continue with the elimination process to be strict and to be scientific, to be certain you're finding the right food group that's the cause. But I agree with a lot of sentiment that if those are not the food groups, why do we have to continue eliminating? That has not yet been clarified.
Okay, and so how strict does the food elimination need to be effective? Like, are we talking in the case of IgE mediated food allergy where there's the risk of anaphylaxis, and so people are focused on very small amounts?
So with the way the studies were done and the way we see it working in practice, you have to be strict, because we don't want to even take the possibility that a small amount of exposure is enough to trigger the inflammation in the esophagus. Once you've identified the trigger, it's not clear if patients should remain on that elimination diet strictly. At that time, there may be wiggle room.
Okay. Now, one of the other questions that came in is, like, if once you've completed a 4 food elimination or a 6 food elimination diet, is there a formal reintroduction protocol that's been designed? Is something like that exists out there?
Yeah, so it's mostly from the research papers. And so essentially the recommendation is, if once you find the trigger food and there is confirmation of healing of the esophagus, the reintroduction of foods is done one at a time, and a camera test has to follow in 8 to 12 weeks to confirm that there is recurrence of inflammation or there continues to be healing.
Okay. Okay, now let's move on to the treatments around PPIs and topical steroids. Remind the audience, how are those two treatments administered, and how they work, and for how long?
So PPIs are pills, and so there's an option of either taking the pill as it is, cracking open the capsule and taking the granules in a teaspoon of applesauce, or having the dissolvable tablet option. For topical steroids, the options are a dissolvable tablet, puffers that you would not inhale. It's kind of funny. You have to take the puff in your mouth and then swallow it. So it is a bit of a relearning for those folks that have asthma, that they cannot just take the puff and inhale it. They have to kind of learn how to hold the puff in their mouth and then swallow it. And the last option in topical steroids is a slurry mix, so a viscous mixture that can either be made at home or the pharmacy can compound it. With both options, you have to take it for 8 to 12 weeks again, and then confirm if it's working. And if it is working, then after that, currently, the recommendation is to remain on the treatment that works.
Now, with some of those, can you speak to some of the long-term use of PPIs and topical steroids? We have had a couple of questions around their safety. You know, from one parent, their son was diagnosed at 15 and is now, I think, in their 20s. I can't recall, I haven't got it quite in front of me, but there's no plan to remove them. Is it dangerous to be on those for years?
So the PPIs have been around for 35 years, and I think in the past 10 years is when we've really started to have the conversation around safety of PPIs. There's been some data suggesting that it can cause Alzheimer's or kidney disease, and the data quality is poor. So we need better data to confirm if the association of PPIs with, the use of PPIs is associated with Alzheimer's and dementia. It may cause bone thinning, but it often tends to be in older patients. Again, the research was kind of questionable because it was done in postmenopausal women. So it wasn't done in young adults, it wasn't done in men. So we need better data. Having said that, if this medication works, for example, PPIs, it is relatively safe compared to the other options that we offer you. And there are other reasons we leave patients on PPIs long term, one of which is Barrett's esophagus, and that is a pre-malignant condition for cancer. So, you know, we do have enough patients out there who take it twice a day if they need to. What we caution is it's okay to recheck every 1 to 2 years if maybe the twice a day dose is not what you need. Maybe you can get away with once a day, but that again means we need to do a scope. So overall, PPIs are relatively safe. There is concern on, you know, if you don't need to be on the medication at the dose you're on, maybe we can find the lower dose that works, but it is a conversation and a scope related checkup that will help dictate that. When it comes to topical steroids, we recently do have about 4 to 5 years of data of people remaining on this treatment, and patients continue to do well. There don't seem to be more side effects as time goes on. The oral hygiene, the yeast infection is the biggest issue. So we kind of just reiterate the importance of that. And it's very well tolerated. We also rely on the asthma literature where puffers are used with steroids long term for the maintenance of asthma control. So we have some indirect ways of looking at the data and saying most likely it's the same for EoE. But when it comes to EoE specifically, 4 to 5 years data is, I think, the most that's been published. So we need more data. Yeah.
Okay. Now on this approved biologic, dupilumab, who's the best target for this treatment? And again, speak to a little bit to as well how that's administered. But who do you think is the best target for this biologic?
So it's usually better to choose a patient who has multiple atopic conditions, or what I mean allergic conditions. So if they happen to have asthma, eczema, and EoE, or if they happen to have sinusitis, rhinitis, nasal polyps, then it's a better medication to consider because it's possibly taking care of many of the conditions they are struggling with one medication. The nice thing with it is once a week, it's injectable, and you can inject it yourself, so you don't have to go to a pharmacy or an infusion center, and you can travel with it. The current patients to consider using it in is really case dependent. As I mentioned, if you have multiple allergic conditions, it may be better to start on that sooner rather than later. But it may also be for some people, if they don't respond to PPIs or steroids, diet isn't an option, then we go to dupilumab. So, and there are times where, you know, there's side effects or reactions to PPIs and topical steroids, which means we go to dupilumab sooner. And right now, Health Canada has not restricted which patients to use it in. So technically, we should be able to use it in all comers.
Okay. A couple of other questions related to medication. We had one question come in about being on allergy medication. In this case, it's Blexten. Can that provide relief for EoE patients if they're on different allergy medications?
So what we do know is that if you take care of your other allergic conditions, you're most likely helping to take care of the intensity of the eosinophilic esophagitis. And similarly, if you take care of the intensity of your eosinophilic esophagitis or even heal it, you could potentially reduce the severity of your other allergic conditions. So yes, it's important to be on your allergy treatments as well as your EoE care.
Okay, and so related to that, I suspect with this question is environmental allergies. How do they contribute to EoE, and what's the best treatment options in that circumstance?
So as I mentioned, we think there's a link with allergens like pollen, but what we don't yet know is exactly which environmental allergen is the trigger and how best to treat it. The general understanding is if we eliminate or remove the allergen from the body, that the body will heal and your EoE will get better. So in terms of how do you eliminate an environmental allergen, it's a question of what is the allergen and whether it has enough evidence behind it in research to be shown as a obvious link. And that's where a lot of research is still pending.
Okay, so now this whole issue about the symptoms not correlating, what the symptoms that people feel not necessarily correlating to the state of the condition and with the response to treatment. What do you tell your patients who say, well, I feel better, and so therefore I think I don't need this treatment anymore? You know, what is it that you talk to them about?
Yeah, and you know, the treatments we have, they're currently not a cure. So I try to counsel patients similar to how, you know, and I give them a good example about blood pressure. So with blood pressure medications that a lot of patients take, if you take the medication, your blood pressure looks good, and so you feel better, you don't have the issues that we're concerned about, and everybody's happy. The trouble is if you stop the blood pressure medications, your blood pressure will come up, and then you are again at risk for all the heart and lung conditions that we worry about. So it's kind of the same with EoE. If you stop the medication, the concern is you will resume the track or the pathway of the history of the disease that you were already trekking along before you started the treatment. So the treatment gives your body a pause. It doesn't actually change the direction of the disease if you were to stop it. And that's because it's not a cure. It's not changing the way your body responds over time. If you take the medication, you're feeling good, your inflammation is healed. You stop the medication, your inflammation returns, and your disease will come back. So you may not notice symptoms right away because you feel good, but unfortunately we know enough to, and we see it enough to know that in 3 to 5 years you will return back to where you were, and then you're again restarting the cycle of fear, the emotional roller coaster, as well as the testing roller coaster. And that is exactly what we see with blood pressure treatment as well.
Okay, so now is that picture different in children? So if is there a possibility of resolution of EoE in children? Is there anything in the literature on that?
So as I mentioned, if the child has erroneously been categorized as EoE when they were really having reflux related injury, then it's possible that as they age, reflux is not going to be as common. We do see a bit of that. And so it might be that they were misclassified as EoE. But when it comes to EoE itself, it's very rare, like it's like less than 0.5% that children will have outgrown their disease when they become adults. It's very rare.
Okay. Okay, so we are running out of time. I'm sorry about that, but I have one question, and then I'm going to turn it over to you to maybe leave our audience with some take-home messages. We had a group of questions related to EoE and immunotherapy for food allergy, and there is, you know, as food oral immunotherapy or desensitization is becoming more available for young children, there has been some concern around the development of EoE. Do you have a perspective on that, or what would be your advice to those that are asking that question? Should I be concerned?
It's a great question, and it's one as gastroenterologist, which is what I am, we struggle with, because we recognize that oral immunotherapy can be linked with eosinophilic esophagitis, but we don't know the exact details. And so often I defer to my allergy and immunology colleagues to guide me on what should be done, because oral immunotherapy is often being started for an allergic disorder or some sort of immune condition that they're already getting guidance for from an allergist. So I usually have to get their input and recommendations and guidance. So I usually don't, you know, make a change in that care. I usually work with the allergist on this.
Well, and for those that are listening in, we do have a webinar coming up in December specifically on immunotherapy with Dr. Philippe Bégin, and we'll certainly pose that question to him since he's front and center and probably would have seen that potentially in the work that he's been doing. So this has been fabulous, Dr. Gupta. There's a lot of content here. If we were to leave our audience with kind of a few key takeaway messages, what would those be?
So I'll try to distill it to 3. It's not normal to keep choking and having difficulty swallowing. Please go see a physician for this. Even though you start treatment and you feel well, we do need to confirm healing on the inside of the esophagus, because we know that symptoms are not always going to match with how you feel, with how things are on the inside of the esophagus, I mean. And lastly, that there are treatments available. They do change and improve your quality of life. You just have to take it. And unfortunately, at this time, you have to remain on that treatment to continue to gain the benefits of it.
Terrific. Well, listen, thank you very much for your time. I'd invite you to turn your webcam off, and I'm going to just wrap up with a few slides. But we really appreciate you spending the time with us today. So in terms of what's next, following this session, you'll get a short survey that asks for your thoughts about today's webinar. Please take a moment to complete the survey. It really helps us to improve our programming and provides us with your insight on topics you would like to see covered. Find more resources to help you understand and manage EoE, including a patient sheet, tips from a registered dietitian, and more at foodallergycanada.ca/EoE. Halloween is coming up, and we need all Canadians to shine a teal light on food allergy. Help make Halloween a safer, more inclusive holiday for everyone. By shining a teal light, you're letting children know that you have food allergy-friendly treats at your door. Join the movement and visit foodallergycanada.ca/shine-a-teal-light to access our tips, tools, posters, and other resources. In terms of things that are coming up, please be aware that we've got 2 more webinars this year. One on November 27th, we'll have a session on food protein-induced enterocolitis syndrome, FPIES, featuring Dr. Anna Novak, who is an international expert on this subject, and she'll review this non-IgE mediated form of food allergy and how to manage it. And then on December 12th, we'll be covering the topic of food allergen immunotherapy and desensitization with Dr. Philippe Bégin. Find out more information and register at foodallergycanada.ca/events. Today's webinar was supported by the Schroeder Foundation, the Sean Delaney Memorial Golf Classic, EpiPen, the Peanut Bureau of Canada, Sanofi, and made possible from donations of viewers like you. Thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share with others who may benefit from this content. This now concludes the webinar.